thank you all for being part of our webinar today. We're really happy that you're with us. Today's webinar is Head, Shoulders, Knees, and Toes, How Pediatric Anatomy Affects Injuries. So again, this webinar today is brought to you by State Farm and Safe Kids. Today, as always, we have our webinar objectives. So today's webinars, we are going to learn about the physical development of the pediatric head, brain, spine, and lower extremities. Also explore how these body regions are different from adults in terms of geometry, strength, and crash injury outcomes. Discuss how different types of child restraint systems protect children at each developmental stage. And then also review the science-backed guidelines for CPSTs to incorporate into their education with caregivers. Next slide. So we're so happy today to have on the call with us Julie Mansfield. She is a research assistant professor at the Injury Biomechanics Research Center at the Ohio State University. And as you can see there, Julie looks great, and she holds a bachelor's degree and a master's degree in mechanical engineering and a PhD in biomedical engineering. So Julie's research focuses on pediatric vehicle safety, especially child restraint system performance and usability. She also works closely with the industry representatives of the Center for Child Injury Prevention Studies, and she has been a CPST since 2014. So again, we are so thankful that Julie is with us today, and with that, I will turn it over to you, Julie.
Great, thank you so much for the wonderful introduction, Stephanie. I'm very happy to be here with all of you today. I hope you're all staying safe and healthy in your respective locations. I think we've got people from all around the world today. So today we will be discussing how pediatric anatomy affects injuries. So I hope you find this information interesting, and I also hope that you find it helpful as you carry out your CPST duties. The purpose of today's talk is to give you some background information about how children's bodies grow so that you can better explain some of our common safety recommendations to caregivers in the field. A key idea for today's talk is that children are not small adults. Hopefully you've heard this tagline already, and I'll be circling back to it several times as we discuss exactly how and why children are different from adults and why children need to be treated and studied as their own category of passenger. This concept is important because in our field, we have a lot more data about adults than we do for kids. We've been studying adults in car crashes since about the 1960s, and it's really tempting for scientists and researchers to just kind of take what we know about adults and kind of scale everything down to make it fit for children. However, as we will learn today, that's not really an ideal way to treat kids. There are a lot of important differences between adults and kids other than size alone. Another key idea for today's talk is that children grow and change very rapidly. So not only are children different from adults, but children are also very different from each other. So a newborn baby is physically very different from a 2-year-old, and that 2-year-old is different from a 5-year-old. A 5-year-old is different from a 10-year-old. So children of each of these ages should really be studied carefully because physical changes happen very quickly throughout childhood. So we could talk about a lot of different topics and examples of how children grow and change anatomically. There are entire college classes on this topic alone. But in our hour today, I'm going to briefly hit on 3 main body regions. So we're going to discuss the head and the brain, and then the cervical spine or the neck, and then the lower extremities or the legs. For each of these body regions, I'll go through some of the most important factors that play into protecting children in crashes. Their physical geometry and proportions, so the differences that we can very easily see by looking at children, and also some of the changes that are less obvious, such as their bone tissue and strength. We will talk about how their developmental rate plays into vehicle safety decisions, as well as some injury outcomes and how children tend to recover from certain injuries in ways that are different from adults. Importantly, we will circle back around to apply this knowledge in ways that CPSTs can use and share it with caregivers at seat checks. It always helps if CPSTs can justify and explain why we are making the recommendations that we give to caregivers. It gives caregivers more confidence in our advice that we're giving them. So I hope you find this information valuable and applicable as you take it out into your endeavors in the field. So let's move on to topic number 1, the head and the brain. This is something that we talk about a lot as CPSTs, and most of us already know. A child's head is proportionately larger than an adult's in terms of both size and mass. It's part of what makes kids so cute, right? They've got these big bobble heads and these big pretty eyes, and we just kind of eat that up because it makes them look different than adults. When a child is born, their head is about 1/4 of the length of their body. The body then grows at a significantly faster rate than the head throughout childhood. And by the time they've reached adulthood, the head is only about 1/7 of the length of the body. Now let's talk about some of the changes happening inside the head, in the brain, which we can't obviously see by looking. So children's brains change with age. One of the main factors behind the changes is because of a substance called myelin. So myelin is what's called a phospholipid or fat layer, which surrounds the axons of neurons. So you might remember what a neuron looks like from biology class. A neuron is a specialized cell in our nervous system that transmits signals around the brain and around the rest of the body. They are long, skinny cells that have their main cell body at one end, and then they're transmitting fibers at the other end. And then connecting each end is this long, skinny part called the axon. So electrical signals kind of zoom from one end of the cell to the other along the axon, at which point the little fibers on the end pass the signal on to either a nearby nerve cell to continue its movement, or a muscle or a gland in your body to tell it what to do. So this myelin coating, or this fatty layer that surrounds the length of the axon, helps to speed up the transmission of the electrical signal as it travels to where it needs to go. So the myelin helps your nerve cells and your nervous system to be very quick and efficient. So it's great from a cognitive standpoint. But why do we care in terms of injury prevention? Well, it turns out that the myelin itself deforms very easily. So it's just made of lipids or fats, and we know fat is, very soft and jiggly, right? It just doesn't really hold its shape very well. So this matters because the amount of myelin in a person's brain cells changes as the person ages. At birth, children have only about 34% of the myelin that they will eventually have as adults. The amount of myelin increases rapidly until the child is about 5 years old, at which point the amount of myelin is nearly equal to adult levels. So that means that children have less of this kind of jiggly fat in their brain tissue compared to adults who have kind of this big bowl of jiggly brain jello inside their heads, right? Now it's a lot more complicated than that. So it's great for transmitting brain signals more quickly, but it definitely changes how the brain responds physically when you get hit in the head or when you get into a car crash. Along with changes in the myelin in the brain, there are also changes in the water content of the brain. So at birth, the brain is about 88% water, but adult brains are only about 78% water. So some of this water is being replaced by fat in the myelin, which of course has different physical mechanical properties when the head experiences physical trauma. If you look at all of these changes, along with lots of other things that are happening in there, we have data that suggests that children's brains are stiffer than adults' brains when exposed to large forces, such as the force you would experience in a car crash. To complicate things, this trend does not always hold true when you're looking at different types of physical trauma, like more mild head strikes, but this trend of stiffer child brains seems to hold true for large trauma events such as car crashes. To further complicate things, age-related changes are not linear, but happen rapidly during the first few years of life, and then more gradually throughout early childhood. So there's a lot of different things happening at different rates, like the water and the myelin, and so it's not always clear what the total effect on the brain is at any given point in development. And then one more thing to consider is that the brain is actually a very complex organ. So I've been kind of comparing it to a bowl of Jell-O. But that's doing all of us kind of a disservice as humans, because our brain is actually made up of very complex structures in different types of tissue in different regions. We have evidence that the brain response to impacts can vary by region and also by direction. So we really need to have a lot of information about where and how the head is being struck before we can even begin to understand what the physical response of the brain might be. We know that people of different ages have different recovery outcomes after brain injuries. So after a very severe traumatic brain injury, or TBI, we have data that shows that younger children really struggle to recover their cognitive performance, whereas children just a couple years older in the 8 to 12-year-old range tend to have better recovery outcomes. If we look at a less severe or moderate TBI, we see that trend holds steady, where younger children and infants have poorer recovery outcomes compared to older children. In mild TBI, though, cognitive recovery is not always well predicted by age. So there are other important factors that might be playing into a person's recovery process. It's interesting to note that this trend of better recovery for older children does not last forever. Once you get into older elderly adults, they tend to have worse recovery outcomes. So it appears that humans kind of peak during adulthood in terms of the brain's ability to recover from trauma, with very young and very old people having a harder time recovering the cognitive functions that might be affected. So it's important to talk about head and brain injuries because the head is the most commonly injured body region for kids in crashes. Looking at this graph, we're considering children ages 0 to 7 riding in CRSs. The height of the bars shows the risk of moderate to severe injuries in each of these body regions. So we're looking at the label says AIS 2+ injury risk. So AIS stands for Abbreviated Injury Scale. It's kind of a standardized way of categorizing the severity of injuries, with an AIS score of 0 being no injury or very minor injury, and the highest score you can get is a 6, which is a fatal injury. So an AIS of 2 or above would represent a fairly significant injury that you would need treatment for. So like a simple fracture or, like a mild TBI or something like that. So in this graph, we're not really considering minor injuries like bumps or scrapes. So the head in red is the most commonly injured body region across all types of crashes: frontal, near side, far side, and rear crashes. From studying the outcomes of actual crashes, we know that the cause of head injuries is almost always, not surprisingly, due to the head striking against something in the vehicle. So the door frame, the back of the front row seat, an adjacent passenger, things like that. So the best way to prevent head injuries is to do everything we can to prevent head contact. That way the way that we measure this is by looking at head excursion. That is how much the head moves during a crash. Obviously, if the head moves less, then it has less chances of striking against anything within the vehicle. So what are some specific tips that CPSTs can use to help reduce the risk of head injury? First, for children in a rear-facing CRS, we obviously want to make sure that we have a tight, proper installation. Tight installations keep the CRS in place and prevent the head from traveling too far around the vehicle. We also want to make sure that we have proper space between the back of the rear-facing CRS and the front row seat. This, of course, varies based on manufacturers' recommendations. Some CRS manufacturers want a certain amount of space, while others might allow light touching of the CRS against the seat back. Finally, we want to make sure that the weight and especially the height of the child are appropriate for the rear-facing CRS. Usually we want at least 1 inch of space between the top of the child's head and the top of the CRS, as shown where the arrow is pointing in the photo. This allows the child to ride up or slightly slide up in the CRS without their head coming out of the top of the shell. Even with a perfectly tight harness, kids still tend to slide up a little bit in the seat during a crash as the harness kind of straightens out and stretches a little bit and the shoulders engage with it. So it's important to have at least 1 inch of space up here. And of course, we know a lot of times caregivers don't get the harness quite tight enough. And so by giving that extra space, it kind of allows the child to move around within the harness a little bit and still make sure that the head is not going to contact anything. Additionally, there is some evidence from testing at Consumer Reports that it might even be beneficial to transition from a rear-facing only or infant CRS into a rear-facing convertible a little bit sooner rather than later. So in their sled testing with both types of rear-facing seats, they found that over half of their sample of rear-facing only infant seats allowed the head to contact the back of the front row seats, while only 4% of rear-facing convertibles allowed head contact. So I want to take a look at this because there are some important limitations to remember in this study. But if we look at these photos from Consumer Reports testing, we can see some possible reasons why they might make this recommendation. These CRSs both contain the 12-month-old dummy. So we know that it's kind of hit or miss as to whether the 12-month-old will still fit in a rear-facing only infant seat. This is usually about the point that most caregivers should consider transitioning an average-sized child to a rear-facing convertible anyway. So this dummy is kind of at the upper end of what we would consider acceptable in an infant seat. So definitely keep that in mind. But in these two photos, at the point of contact, you can see that the head of the dummy is sticking out of the top of the infant seat on the photo on the left, and the convertible seat on the right is a little bit taller, and it keeps the head better contained within the shell of the CRS. So again, this dummy is fairly large and fairly tall to be in that rear-facing only infant seat, but you can just tell between the two shapes of the two different CRSs, the convertible is a little bit taller and kind of keeps the head enveloped in the shell a little bit more. And then here's another angle of these two conditions. So we've got the infant seat on the left and the convertible on the right. In a frontal crash, it's like I said, it's common for the child to kind of ride upward a little bit, even when the harness is tight. And you can see here that having that extra space around their head might be helpful in preventing head strikes in some of these conditions. So if we switch gears now and think about forward-facing CRS, what are some tips for CPSTs to share to prevent head injuries here? Again, a tight, proper installation is your best line of defense. A tight harness is especially helpful in a forward-facing CRS, since the harness is really doing the full job of restraining the child, unlike in a rear-facing CRS, where the back of the CRS is also helping to support the child. And as we all know, the main tool for preventing head injuries in forward-facing CRS is the top tether. The top tether reduces head excursion by about 4 to 6 inches. In these crash test photos, you can see the difference between a forward-facing CRS installed with a top tether on the top photo. The head only comes as far as the green line, and in the bottom photo, which is the exact same setup without the top tether, the head of the dummy extends several inches further to the red line. If you're interested in viewing the full videos showing these examples, you can search on YouTube for Buckle Up with Brutus. That is our team here at OSU, and we've made several educational videos showing these types of conditions and a few others. So that wraps up our discussion about the head. Now let's move downward a little bit and talk about the neck or the cervical spine. First, we'll go back to our graph of different injuries. So we've already discussed the head in red. Neck and spine injuries on this graph are shown in blue. You can see that neck injuries are really not that common, at least compared to other body region injuries, which is very good. The catch here is that when neck injuries do occur, they're very serious and the outcomes are typically not good. So even though they're rare, they deserve our attention because of their inherently serious nature. So this is especially true for certain age groups of children, which we're going to discuss shortly. First, let's look at some anatomy of the cervical spine. The very first vertebra at the top of our spine is called C1. So C stands for cervical, and then they're all numbered starting at 1 through 7. The top one, C1, also has a special name. It's called the atlas because it's a little bit unique. The photo on the right is an overhead view. So we're looking down kind of on the top part of the bone. This is an adult C1. The base of the skull sits directly on top of C1. So it's got these flat little divots or facets. And that is where the skull kind of rests directly on top. These little divots allow the head to rock forward and back. So like when you're shaking your head, yes. And then the entire vertebra is shaped like a ring. In the middle of this ring, there is a protruding part of C2. So the bone, the vertebrae right underneath it, it kind of sticks up in the middle of this hole and it allows the head to rotate side to side. So like when you're shaking your head, no. In the adult, this ring shape is fully formed. And then you also have the two smaller arches on each side. And this is where the arteries and veins go through. So like I mentioned, this photo is showing an adult C1 vertebrae. If we go backwards in time and we look at C1 for a newborn, it looks very, very different. The newborn has only two small bony regions, which are connected by cartilage only. So the actual bony part of the first vertebra in a child just looks like this. And it looks quite a bit different from what we were looking at for an adult. Once the child is about 3 years old, we can start to see the vertebra resembling the adult ring shape. We see the development of a third bony region, which has formed into this top anterior arch up here. And then the other bony regions have grown larger and are closer to connecting to one another. However, there are still some weak points in the ring called sychondroses. These are still regions of cartilage that connect the 3 distinct areas of bone. So these are the points that are especially susceptible to injury and remain so until the bones fully fuse together or ossify a few years later. If we take a look at the next vertebra down, C2, we see a similar story. C2 is also called the axis because its shape is also unique compared to the rest of the spinal column. It has this dens or apex up here at the top that protrudes upward, and that kind of goes through the middle part of the ring of C1, again, which kind of allows your head to spin side to side. So you can see in the newborn on the left that this vertebra starts out as 4 distinct bony pieces connected by cartilage only. And then the gaps have pretty much closed by age 3 on the right, but weak points still exist as the bone continues to form and harden and takes on its final adult shape. Another interesting feature of the spine to discuss are the facet angles. So facet angles refer to the surfaces of each vertebra that connect the vertebra above and below it. So in this photo, so this is a side angle of an adult spine. In the photo, you can see the surfaces that are highlighted in red. In an adult, the surfaces are at a fairly steep angle. So if you envision a force kind of pushing on the side of this spinal column, the angle of the facets kind of interlock and help to resist that sideways force. The assembly of bones on top of each other is strong because each spine kind of interlocks with the ones above and below it. In a child, however, those facet angles in red are more shallow and more horizontal. So if you picture these red lines just kind of going straight across horizontally, and the spine bones just kind of sit on top of each other like a stack of blocks. So if you impact that stack of blocks from the side, the bones aren't really interlocking anymore, and the bones would just kind of slide out of alignment from one another. Additionally, if we look at the ligaments which hold the spinal column together, the pediatric ligaments are more stretchy than adults. So the pediatric bones don't interlock with each other quite as tightly due to their shape and orientation, and the connective tissue that does hold them together is quite stretchy and yielding. So it's not until the person grows up a little bit that those ligaments become more stiff and substantial and really hold your vertebrae together in a more meaningful way. The stretchiness of a child's spinal column is interesting and poses a unique problem. So when we use the term spinal column or vertebral column, we're referring to all the bones in the spine kind of stacked on top of each other to form our full spine from head to tailbone. A child's vertebral column can stretch up to 2 inches without injury to the bones or ligaments because those connecting ligaments are so stretchy and pliable. However, we need to remember that the spinal cord is housed inside of the bony structure of the spinal column. The spinal cord, of course, is a very important bundle of nerves that control your entire body. The spinal cord can only stretch 1/4 of an inch before it gets injured. So the spinal cord is very fragile, but for children, it's housed inside of a column of bones that is really not yet very protective because they aren't fully formed and they aren't held in place tightly yet. From a medical standpoint, you can end up in a situation referred to as spinal cord injury without radiological abnormality in surrounding bones and ligaments. And it's got its own special acronym. I'm not sure if you're supposed to pronounce that as a word or not, but it's got its own acronym if you want to Google it. So when a doctor in the ER looks at these images of the spine, they might, check the bones for fractures. They might kind of check the alignment of the spinal column, and they might not see anything that looks obviously broken or damaged. However, the little white shadow in the middle of the spinal column, so this little shadow here and this shadow here, this indicates an injury to the spinal cord. 90% of these types of spinal cord injuries without damage to their surrounding bones happen in children under 18 years old. So I'm not a doctor, and I have to assume that they're trained to look for injuries like this. but they're definitely a little bit harder to spot on medical imaging results compared to something like a very obvious fracture of the bones. Now let's talk about how cervical spine injuries tend to happen to children in crashes. The first scenario to discuss is a non-contact injury, which is also called inertial neck injury. This refers to a situation where the crash forces pull the head towards the direction of the crash. So like a frontal crash in the photo shown here, but the head does not contact anything within the vehicle. So just the mass of the head is kind of pulling on the neck. And in some cases, it pulls hard enough to cause an injury to the neck. This type of injury is rare, but some have been reported. The risk is higher in children than adults due to some of the things we've already talked about. They're relatively large heads, undeveloped spine, and flexible neck ligaments. Usually, however, spine injury due to head contact is the more common cause. This happens because the neck stretches during the initial phase of the crash, and it becomes more vulnerable to injury when it's in that stretched position. The tension makes it less strong than, compared to when you're just like in a neutral sitting up position. So the neck stretches, and then when it's stretched, it receives a sudden jolt when the head strikes against the seat back or the side door. And that energy transfers through the head and into the neck, which can cause vertebral fractures, dislocations, and spinal cord injuries. Injury outcomes change as children age. So younger children tend to have more upper cervical spine fractures, especially dislocations that occur between the base of the skull and C1. This seems to be the weak point of the spinal column for younger children. Unfortunately, injuries in this area tend to carry a higher risk of fatality compared to other spinal injuries. Older children and adults tend to have more lower cervical spine fractures, which are still very serious, but typically not as deadly. So what tips can CPSTs put into their back pocket to help caregivers understand and prevent neck injuries? The first one we all know, encourage rear facing for as long as possible. Rear facing CRS reduce neck forces by keeping the head supported and the spine aligned. They help to reduce the risk of those inertial or non-contact head injuries. Since most neck injuries are associated with head contact, it seems to stand to reason that if we can prevent head contact, we will also reduce the risk of neck injury. So the same concepts apply here. Encouraging top tether use will help prevent head contact, which in turn reduces the risk of neck injury. And again, using that top tether saves us about 4 to 6 inches of head excursion. Now, let's move on to our last body region, which we'll discuss today, the legs or lower extremities. If we come back to our chart here, we see that lower extremity injuries are in gray. They are the second most commonly injured body region for frontal and near side crashes after head injuries, and the third most common in far side and rear impacts. So they account for a significant portion of the injuries that we see from crashes. Injuries in the lower extremities are generally not as life-threatening as some of the head and spine injuries we've talked about, but as we will discuss, these types of injuries can be very detrimental for children. If we take a look at how kids' lower extremities develop, we find rapid growth rates in infancy, and then a plateau in early childhood, followed by another period of rapid growth in adolescence. Limb segments tend to grow at different rates from one another, and we see areas of slower ossification, similar to the regions in the spine that we already talked about. For example, a child's kneecaps are cartilage until they ossify or turn into bone around age 3 to 5 years. So when you're looking at that 2-year-old child who's rear facing and the caregiver is worried that they aren't comfortable, you can tell them that the child is just fine because they don't even have real kneecaps yet. Their legs are very stretchy and very bendy, just like the rest of them. Children's lower extremities also have growth plates to consider. So growth plates are also called epiphyseal plates or physes, and they're areas of cartilage that are weaker than the surrounding bone, ligaments, and tendons. They are the last portion of the child's bones to harden, usually around age 15. And this happens slightly sooner for girls and later for boys, just based on when they go through puberty. Most growth plate injuries heal with no complications, but sometimes growth plate injuries can increase the risk of crooked, accelerated, or stunted bone growth. The severity of these injury outcomes depends on the severity of the injury itself, the age of the child, and the location of the injury. the knee area seems to be the most sensitive. Let's talk about lower extremity injuries and crashes. So everybody take a minute to think about, which do you think is safer for a child's legs, rear facing or forward facing CRSs? So I think most of us have talked to caregivers who are often concerned about the legs in rear facing mode. They say, oh, they're bent or they're squished or they're touching against the seat back. And they want to know if these situations are dangerous for their children's legs. A good response for these questions is, we don't have much data for leg injuries in rear-facing CRS, but the data that we do have shows that there is a risk of leg injuries in forward-facing mode too. So this table is from a paper by McMurray et al. In 2017. They looked through a database of crashes that happened in the United States. They showed that the rate of lower extremity injuries for children in rear-facing CRS is about 0.1%, and the rate in forward-facing CRS is about 0.3%. These trends are true for children in both their first year of life and in their second year of life. So just by looking at these numbers, we might be tempted to say that the risk of leg injury is greater in forward-facing and the legs are safer rear-facing. In actuality, it turns out that the number of lower extremity injuries in this database that they studied is small. So these sample sizes are not large enough to say that there is a statistically significant difference between this 0.1 and 0.3 injury rate. So statistically speaking, these numbers are equal. But what we can say is the child's legs appear to be equally safe in rear-facing and forward-facing modes. So turning your child forward-facing does not mean that their legs will be safer. And since we know that there are benefits for rear-facing for the head and spine, we always want to keep the kids rear-facing for as long as possible. So let's explore a little bit more about how leg injuries can happen in a forward-facing CRS. Here we see an image from a frontal impact. So you can see the head, arms, and legs all flailing forward towards the point of impact. When those legs flail forward, they hit the back of the front row seat. So the impact against the seat might cause an injury, or once the legs are up like this and kind of braced against the seat back, sometimes the child continues to travel forward as their torso loads into the harness. So the forward movement of the weight of the body presses the legs into the seat back with a lot of force. So this might also cause some injuries aside from the initial striking of the seat back. So I was able to find several papers documenting these types of lower extremity injuries for children in forward-facing CRS from real crashes. So we know that they actually happen on the road. So when a caregiver says, hey, I want to turn my kid forward-facing because I think it will be safer for their legs, you can confidently say that turning forward-facing is not necessarily going to protect their legs. There is some compelling evidence that leg injuries can still happen in forward-facing seats. So to summarize our tips for leg injuries, we want to encourage rear-facing use for as long as possible because we know that turning forward-facing does not necessarily protect the legs any better than rear-facing. We also know, of course, that there are other benefits for rear-facing for the head and neck, and so we want to stay that direction for as long as possible. And also ensuring tight installation of the forward-facing CRS will also help to keep the child and the legs away from that front row seat back. And of course, we always want to remember to use that top tether as well. So I wanted to show this slide to kind of put things into perspective. So all of the things we talked about today, everything we know about children, about their size and proportions and differences in their bone structure and strengths of their ligaments and tissues, it all kind of boils down to this crew right here. This is the family of crash test dummies that are most often used in the USA. There is a dummy the size of a 12-month-old, a 3-year-old, a 6-year-old, and a 10-year-old. They are all made out of steel and aluminum and rubber and vinyl. So I'd like you to think about all the complexities that we talked about today regarding real children, all of their different bones and all the different parts of their bones and how they change and how they develop over time. And consider whether these dummies are really able to capture everything going on inside of children's bodies. The answer, of course, is no. the human body is vastly complicated and cannot be reproduced in a dummy factory. Also, these child dummies were originally designed on adult data. So scientists and engineers took what we know about adult bodies and adult responses and crashes and scaled everything down to the size of children. This table here shows some of the end results of a lot of very, very complicated math that goes into techniques like that. So hopefully, after what we learned today, you can see some of the potential problems with that approach. Now, we do have some data specifically on children, so engineers have some idea of what these dummies should end up looking like and how to use them. So, you know, they're not just shooting in the dark. Everyone in the field is doing the best they can with the information that we have. But the take-home message here is that crash test dummies are simply tools that we use to help us understand certain things about crashes. And they're very useful in a lot of cases. But we need to make sure we understand the limitations of the dummies to really use them correctly and to interpret the data that they give us correctly. So we always need to remember to compare back to actual children in actual crashes to see what types of injuries are happening and how they are happening to make sure our dummies are giving us realistic information. For our friends in Europe who are listening today, I didn't want to leave you out. This is the Q series of dummies, which is predominantly used in Europe and other places around the world. This family is a little bit more advanced and a little bit newer than some of the dummies in the US regulations. The exciting news here is that here in the US, we're starting to use some of these guys in testing, especially the Q3S, which is a 3-year-old specially designed for side impact. So NHTSA just released some information a few months ago describing how the Q3S will be used in our new CRS side impact regulatory testing, which is a really fantastic advancement and will help us keep kids safer in side impacts. So a good way to summarize our talk today is to remind you all that children are not small adults. They grow and change rapidly in terms of geometry, proportions, and strength of their bones and tissue. These factors all affect crash outcomes, and scientists and researchers are still learning more about children to help them design better tools and CRSs. So while we make progress all the time, we still have a long way to go. So I'm going to leave you with one of my favorite comic strips, Strange Planet by Nathan Pyle. If you're not familiar, I highly recommend you check it out. It's hilarious. My email is at the bottom if you'd like to follow up with me directly. So thank you for your attention today. And it looks like we should have plenty of time to take some questions.
Great. Yes, we do have lots of time, Julie, for some questions. So if you do have more questions, please just add them into the Q&A box and I will get to those as I can. And Julie, in the chat box, you will see a lot of great comments for you, people really appreciating your webinar today. And so thank you again for being on for us. So our first question, Sonia asks, what does it mean when you say a child's brain is stiffer?
So stiffness is, I mean, I think we all kind of understand what stiffness is in kind of a day-to-day way. Stiffness is also an engineering term to kind of describe material properties. So if a child's brain is stiffer than an adult's, it's going to kind of transmit forces a little bit faster and quicker. So if you picture like a, I don't know, like a stiff like bowling ball or something compared to like a bouncy squishy basketball, the forces are going to translate through that hard stiff bowling ball faster and more quickly and more efficiently than through the basketball, because the basketball can kind of deform and flex, and when it does that, it absorbs some of the energy. So to say that a child's brain is stiffer, it just kind of changes the way that forces are translated through that material. And to be honest, I can't even really necessarily say the outcome of that in terms of, you know, what it means for diagnosing a concussion or other specific types of injuries. I would have to do a lot more reading to come up with those answers, but just the brain itself is kind of stiffer and harder than an adult's, and that's going to change the threshold at which that child experiences an injury, such as, you know, a kind of generic TBI is kind of a catch-all phrase for a brain injury, but you know, a concussion or a specific thing like a hemorrhage in the brain or something like that. So it's just different between adults and children.
Great, thank you. Melissa asks, have you found a more upright install to be beneficial for the risk of head injury in a rear-facing install?
That's a great question. I don't have any data to support whether a more upright install would be better or worse. My initial thought is that a more upright install would kind of help keep the head contained within the shell. So even if the child rides up a little bit, that rear facing seat will still be more upright and the shell will kind of continue to be around the head and surround the head. Whereas if you envision a very reclined rear facing CRS, the crash forces might kind of pull the child up that back and kind of ride up into the shoulder harness, and the head could kind of come up and travel a bit more outside of the shell and might hit, similar to like these photos I showed from that Consumer Reports testing. Let's look at that quickly here. So like these photos here. So I will say maybe a more upright seat might help protect the head a little better. We do know that a lot of manufacturers recommend or allow a slightly more upright seating position as the child gets older in the rear facing convertible. So you might see the sticker on the side and the kind of angle indicator on the side that says the younger child needs to be reclined more, whereas the older child can sit more upright. That has a lot to do with the breathing of the child, because a younger child needs to lay more flat to keep their airways open and the head back and in a safe position. Whereas an older child who has head control can sit upright and control their head a little bit better just during normal sitting and sleeping and things like that. But I suspect part of the reason of that recommendation might be that the seats test perhaps a little bit better for older children in those more upright positions, because it does kind of keep the head contained. So after all that rambling, the answer to your question is I'm not sure. Definitely always follow the manufacturer's instructions for children of specific weights or heights and what recline angle their seats are supposed to be at, because they've done a lot more testing with their specific products than I have. So
great. And while you're looking at slides there, Julie Bridget had asked about the slides that have the stats with rear-facing only head contact compared to the rear-facing convertibles. If you could just pull that slide up again, she was trying to write some of that information down. And if you could just go over that slide one more time for her.
Sure. So I think it's this slide you're referring to. This is a Consumer Reports study. So the title of their study is Why You Should Buy a Convertible Car Seat Sooner Rather Than Later. So I highly recommend you look up that study itself. They have some nice articles about it, and they do really great work at Consumer Reports. So they didn't test every single seat on the market, but of the ones that they did test, they found that, again, for that 12-month-old dummy, the head tended to, even if the head was kind of contained within the shell of the infant seat to begin with, it always slides up a little bit as it engages with the harness. And so they found that those infant seats are just smaller, right? And the shell of that infant seat is not as tall. And so more of them allowed the head to kind of ride up and contact the back of the front row seat in their sled setup, compared to the convertible seats, where I think they only had 1 or 2 convertible seats, which equaled 4% of their sample, where the dummy kind of ride up and allow head contact. So again, this is not to say that infant seats are not safe, especially for the little teeny babies who still have plenty of room to grow in them. These infant seats were tested with a 12-month-old dummy. So again, we know around that age, the child is generally almost too tall for that infant seat, just based on the manufacturer's recommendation. So this is really kind of pushing the limit of the height limits of those seats. And they did find that, when that child's head is so close to the top of the infant seat, just in a normal position, if you introduce these crash forces, it has a little bit greater chance of riding up and contacting the back of that front row seat that you can see kind of simulated in this study.
Great. And Sherry and Antonio, you had asked in the chat about the CEUs and this presentation being recorded. And yes, it is being recorded. It will be on the cpsboard.org site by next week. And then you will be getting a CEU event ID number tomorrow afternoon for that as well. So Meredith asked, can I just clarify, is it potentially safer to have a convertible rear facing than an infant rear facing beginning at what age?
So I don't know the answer to that question. I'm not sure there is a clear-cut answer. I would say follow the manufacturer's recommendations. If you have at least 1 inch of space in between the top of the child's head, where did that slide go? At least 1 inch of space. I just saw it. There it is. If you have at least that recommended 1 inch of space between the top of the child's head and the top of the infant seat, you should be fine. You know, follow the recommendations there. If, you know, if the top of the head is approaching that 1 inch mark, you might want to consider, you know, a convertible seat a little bit sooner rather than, you know, kind of maxing out that particular category. Just because, you know, we always talk about you want to max out either the height or weight of the seat rear facing, which is true in terms of keeping the child rear facing before you turn them to forward facing. And this is just kind of, I guess, another piece of advice on top of that is to really pay attention to that height factor and make sure the head of the child is within that that 1 inch. Yeah.
Great. And Keisha asked if you'd be able to elaborate on the rear facing head injuries a little bit more. Are the head injuries caused more often by the head extending beyond the protective shell of the rear facing child restraint, or is something else causing those injuries?
So typically, I'm going to kind of walk through this as I know these facts. So typically head injuries are caused by head contact within the vehicle. So I would wager a guess that that means that one way or another, that head is extending outside of the shell in some way. So it might be because that shell is really kind of rotating downward and the head is kind of stretching out the top like you see in these pictures. These are just frontal impacts. So we also need to consider side impacts, or we call it oblique impacts, which have kind of a frontal and side component. So the child is kind of moving diagonally. Sometimes the CRS can kind of, you know, tip side to side a little bit. So the head might be kind of swinging out the side of the CRS in like a side impact. So the CRS is kind of, you know, tipping sideways a little bit and the head is striking different parts of the vehicle. We also need to remember that a lot of child seats in these data sets that we're looking at to determine the types of injuries, a lot of these child seats aren't being used correctly. So if you have a rear-facing infant seat that's being used perfectly correctly, you know, it should be fine. I don't want people to come away from this talk thinking, oh, you know, Julie said infant seats aren't safe to use. That's not what I'm saying here. As long as you're following the manufacturer's instructions, those infant seats should be good. Even within this consumer report study, you know, that 12-month-old dummy might have been very close, if not past the height limit for some of those seats. And so we need to be careful how we're interpreting this. But anyway, back to the point about the data. A lot of the head injuries that we see in real crashes are because those CRSs aren't being used correctly. So maybe that harness was loose, or maybe the installation was loose and it allowed the whole CRS to kind of tip over, or the harness was loose and, you know, the head really extended further out of the shell than it should have if the harness was tight. Or, you know, maybe it was so loose that the child slid out of the harness and then the head was impacted. Maybe the child wasn't wearing the harness correctly at all. Maybe they had their shoulders out of it or something. So yes, typically head injuries happen because of head contact against some point in the vehicle, which implies that the head has kind of escaped the shell of the CRS somehow. But most likely that's not due to any defects or any weaknesses in the child seat itself. It's probably due to misuse of the child seat. So as long as you're using these seats correctly by manufacturer's recommendations, in terms of spacing, in terms of tight harness, we wouldn't expect to see head injuries from a properly used seat.
Well, we just have some more questions. So if you're up for it, Julie, we'll just keep going for a little bit longer. Thank you. Elizabeth asks, were the dummies based on adult males? It's her understanding adult female dummies are also based on adult male information.
I believe that is true in most cases, yes. So interesting history lesson here. When vehicle crash safety first became a field of study back in the 60s and 70s, they found that men drove a lot more than women back in the 60s. You know, men were commuting to work every single day, where in general, a lot of women were staying home, you know, being housewives and raising kids and just kind of, you know, going to the grocery store and back. And so there is some data to show that, you know, back in those days, men were on the roads traveling more miles on average than most women. And so scientists and researchers said, oh, well, you know, let's start with men because those are the types of people who are in cars more and who are getting in crashes more and are getting injured in crashes more. So we're going to start studying men before we focus too much on women. So that's kind of where the field started. And then, of course, you know, in 2020, today's world is quite a bit different than it was in the 60s. And, you know, women are traveling just as much as men and in cars just as much as men. But unfortunately, you know, we just kind of got a slow start in studying women. And, you know, obviously I'm a woman and that concerns me a little bit. So we have gotten better in the more recent decades in doing studies specifically on women, for women, looking at the types of injuries that females are getting in car crashes and kind of the special considerations. Well, not even special. I mean, women are 50% of the population, right? So some of the considerations for females specifically, and we are starting to see that data come into the papers and come into the databases. But yeah, the short answer is yes, that a lot of the data in our field was originally collected on adult men, and we have used a lot of that data to kind of scale and kind of correlate and estimate what that means in terms of females, who of course tend to be smaller than males, tend to have a little bit different bone structure and bone strength than males, and also children. We've scaled a lot of that same data down to children. So that's kind of a very, very long story short. It's a really interesting history if you want to look into it. But yeah.
Great.
Question.
Lonnie asks, would it make sense to advise parents to push the front seat all the way forward if there's no adult in it in front of a forward-facing child restraint?
That's a great question. To be honest, I am not sure. In terms of removing obstacles so that the head can't contact and, you know, the legs can't contact, it's tempting to say, you know, yes, you want to create as much space around that child restraint as you can. I will say that that's typically how they're tested in our federal standards. So this study from Consumer Reports is a little bit different because it has this front blocker plate, they call it, to kind of simulate the back of the front row seat. In our typical child seat regulatory testing, there's nothing in front of them. There's no front row seat and they just kind of travel through space. So that is kind of how child seats are typically tested. So I would say, yes, that is probably a safe condition if you have just kind of all that space available for the child seat to travel through. It should work exactly as intended. We all know that's typically not possible in a lot of vehicles. You have a front row seat in vehicles and it's not always possible to pull it all the way up front out of the way. And I wouldn't really say it's necessary, you know. There could even be some benefit in, you know, the back of that CRS kind of contacting the vehicle seat back and kind of stopping that rotation. If you think about it, that's kind of what a load leg does, right? A load leg on a rear facing seat provides a point of contact against the vehicle in a way that's not going to harm the head, but in a way that's going to kind of prevent that rotation and kind of slow the rotation and absorb some of the loads from the child. So I don't want to say, I really can't answer that question. Those are a few of the different factors that go into it. we don't really have evidence either way to say whether moving that front row seat out of the way is safe or not safe. And honestly, the answer, you might see a pattern here in my answers, or just, it depends, you know, it depends on the child's seat, on the type of crash you're in, on how the child's fitting in that seat. I definitely, as long as you're following the manufacturer's instructions on how that rear facing seat is sitting against the front row seat or sitting near the front row seat, I wouldn't have any concerns with having a seat, you know, near contact with the rear facing CRS. That's how it is in most vehicles. And, you know, we see those rear facing seats perform very well. And so I wouldn't be concerned about that at all, no.
Well, I think that that is the time that we have for the questions. There are more questions. Julie will be getting those. And so hopefully we'll be able to get those answered. But there was a great comment in the chat that I just wanted to close. And then Julie, if you wouldn't mind going to the last slide for me, that would be great. But Nicole said, this has been great. Thank you. As a new technician, this is great information for her. She's new to her role. Great information for her and very easy to digest. And so we're so grateful that you were on today, Julie, and just want to give you a minute if you have any other final thoughts for those that are on the webinar.
No, I think that's it. You know, I hope everybody out there realizes that, you know, I'm a researcher, so I'm just kind of absorbing all the information that's out there and doing some testing in conjunction with some of these questions that are coming up from CPSTs and from people I'm talking to in the field. So if you have any questions about specific products and the safest way to use a specific product, please, please, please contact the manufacturer of that CRS, get their advice. They know a lot more about their products than I do. So again, a lot of this data that I'm presenting today is very general and kind of just some trends that we're seeing. But if you have a specific situation you're ever concerned about or have questions about, talk to those manufacturers. They are excellent, excellent resources. They have some great folks on their team who can help answer some of your questions about their products. So thank you. And yeah, please feel free to reach out if you have any questions for me as well.
So again, thank you. And before we go, I just want to remind everyone that a survey is going to come up right after the webinar. But then again, tomorrow afternoon is when your confirmation email will come, and that will have your event ID on that confirmation email that you will put into your profile. If you do not get it, check your spam filter. And if it's not there, then you can just send me an email. I'll confirm your attendance and I'll send you a confirmation email. So again, with that, thank you, Julie, for your time today. Thank you all that were listening in, and it was a wonderful webinar. Everyone have a great and safe day.